Good morning, everybody. Welcome to our monthly series of discussions on various topics of importance to the business community in New Jersey. My name is Howard Burns. I'm the editor of NJBIZ, and thank you for being here. This morning's discussion is one that is in the news. It's critical to all businesses. Some of you may have this in your workplace and you don't even know it. It's problem of opioids and its impact on the workplace. And I would like to introduce our moderator for this panel. It's Valerie Mielke, the Assistant Commissioner at the New Jersey Division of Mental Health and Addiction Services, Department of Health. Valerie Mielke is the Assistant Commissioner for the New Jersey Division of Mental Health and Addiction Services. The division is responsible for the coordination, administration, management, and supervision of the institutional and community public mental health system. And it's also responsible for regulating, monitoring, planning, and funding substance abuse prevention, treatment, and recovery support services. So now, without further ado, I'd like to bring up our moderator, Valerie Mielke.
Good morning. It really is a pleasure and an honor to be here this morning with really this esteemed panel of experts representing health plans, healthcare administration, quality and safety, treatment, care coordination, federal and state legislative, statutory, and enforcement matters pertaining to the opioid epidemic. This certainly is an important issue here for the state of New Jersey as well as nationally. And so without further ado, I'd like to ask the panelists if they would introduce themselves to you and a little bit of their professional background. I'd like to start with Dr. Omar Baker.
Thank you. First of all, I'd like to really commend NJBIZ for assembling a panel on this topic. It's at the forefront of what's happening, and it's very important that we continue to have a dialogue. And also to give credit to Valerie and her counterparts at the DOH. New Jersey's really, we'll talk about it, but leading the charge amongst many of the states in this nation with the new administration under Governor Phil Murphy. About myself, I'm a pediatrician by training. I'm co-president and chief quality and safety officer of the second largest medical group in the state of New Jersey, Riverside Medical Group. We're a primary care and multi-specialty organization, and we've found a way to integrate behavioral and mental health with primary care, and I'll talk a little bit about that. And I also was honored and humbled to serve as co-chair of the healthcare committee to the governor, which came out with the recommendation of January 1st of all the policies and procedures that we hope to institute in the first 120 days and beyond. And I'm really honored and humbled to be with such great experts on this panel. I look forward to a good discussion. Thank you.
Good morning. My name is Bartley Bryt, and I'm the Chief Medical Officer at a health plan administrator named Brighton Health Plan Solutions. And as an insurer, we see all sides of the healthcare system, delivery system, patients, as well as payers. We have two main products. One is focused on the Taft-Hartley world, that's named MagnaCare, and another healthcare product named Create, which is a marketplace of delivery systems that is focused on the commercial product. And I thank you very much for having me here. This is a concern for many of our clients, certainly our union clients, even more than our non-union clients, because manual laborers oftentimes have musculoskeletal injuries that lead to prescriptions, that lead to untoward consequences. And so we'll talk about that here, hopefully not hysterically, because I don't think we want to get hysterical about it. Thanks.
Good morning. My name is Jack Wenik. I'm a member of a law firm, Epstein Becker Green, which is a national healthcare law firm. And I thank you, the NJBIZ, for having me. My practice is in the enforcement area. I was a federal prosecutor for 7 years, and I've been on the private side now for about 20. And the whole opioid crisis has led to a lot of initiatives, both at the state and federal level, that we've been counseling our clients as to how to respond to these initiatives and how to limit exposure and liability in this area. And hopefully I'll have something interesting to say, but less technical than the clinicians that surround me here that have much more knowledge than I. Thank you.
Hi, my name is Dr. Alana Letourneau. I am a physician by training with a background in neuroscience research and health technology. I am the Vice President of Clinical Program Strategy at Concordia Care. Concordia is a specialty risk transfer company focusing on care coordination for injured workers while applying our foundation in behavioral health. Thank you.
Good morning, everyone. I'm Bill Bruck. I am the Director of Medical Services at Seabrook. Seabrook is a nonprofit treatment facility located in southern New Jersey. We have 150 beds, both short-term and long-term recovery at Bridgeton in Upper Deerfield, Cumberland County. We also have 5 outpatient centers throughout the state. I work in conjunction with our medical director, Dr. Joseph Ranieri. He is the president of ASAM in New Jersey. He's been a leading voice in treatment addiction in New Jersey and throughout the country. And at Seabrook, we live this crisis every day. We see people from every walk of life, every profession, and it truly is a crisis. In addition to the opiate issues, and I'd like to make sure that people understand that alcohol hasn't gone away, benzodiazepines haven't gone away. The problems that we're seeing every day are just monumental, and it's great that NJBIZ and this panel is here today, and that this topic is getting the attention that it needs, and I'm honored to be part of the panel. Thank you.
Wonderful. Well, to start, I just wanted to ask our panelists, just to make sure that we're all working off the same song sheet here, is to talk a little bit about addiction and what addiction is.
I'll be happy to start. Yeah. Addiction is many things to many people. It really is not. The lay public has an idea about addiction, that it's a certain socioeconomic class. It's people that maybe are unemployed, but in reality, addiction touches just about everybody. These days, I think there's very few people who doesn't know someone who has a family member that's in addiction, or is in addiction themselves, or has a friend or a coworker that has experienced addiction. And it really is a complicated topic in that there's a predilection that some people have towards addiction. There is many things that have really contributed to it. We've had, the opioids have been around for quite some time. There's been a push over the past 20 years that pain is the 5th vital sign, and that it was almost unethical not to treat every last bit of pain. So there's many things that have kind of really brought us to where we are with addiction right now. It's not only a personality matter. There's a mental health component. We see lots of folks that have co-occurring mental illness, and it really becomes a chicken versus egg kind of a thing. Did the mental illness come first and lead to the addiction issues? Did the addiction issues bring on mental health issues? So, like I said, it's a very complicated issue, and it's very challenging. We see lots of folks every day, and there's a lot of work that yet to be done with addictions in this state and this country.
I'd like to add a comment, and maybe the way to start is with a quick story. So when I was in practice, I'm no longer in practice, I had 2 patients. One patient, I'm in seeing patients, and out in the waiting room, I'm told by one of the nurses that there's this patient who's screaming hysterically in pain. Because we can't talk about addiction and opiates without talking really about pain and how you get there. And so this patient comes in, person is hysterical, I'm a pediatrician as well, and the parent is also just totally distraught. Turns out this young lady has a sprained ankle. I have a different patient, different time, and I'm seeing my regular patients, and in walks a young man, 18 years old, very still, walking in. He just walks in very calmly, comes into the room. For those of you who are clinicians in the house, I know some are, this person had a totally rigid abdomen. They had a perforated appendicitis with something called peritonitis. This person showed no signs of pain whatsoever. And so pain and addiction is as much in the mind as it is in the body. And so there's another phenomenon in medicine which is called phantom limb pain, where you can lose your limb and yet have pain, very real pain, in a limb that no longer exists. So as we talk about addiction and opioids, we've got to talk about the context of what the patient is talking about. And so it's a complicated issue, and what two people experience is very, very different, and whether you're susceptible to the characteristics of opioids depends very much upon the person as well as the drug.
And if I could add to that and just echo what the two panelists said, addiction really has no age, has no gender, has no socioeconomic status. And I think it's very important as clinicians and people in healthcare to understand that addiction is a disease. These are not bad people. The majority of them are very good people, but they suffer from a disease and were put in a circumstance, whether they initially took a pill from a kitchen cabinet or got a medication for a fractured ankle. And it's a combination of genetic and environmental factors. Until we treat addiction the same way we treat diabetes, hypertension, and medical diseases, I think there's still going to be a stigma around it, and it's going to be very challenging. So that's one of the big barriers, to understand that mental health is no different than physical health, and integrating the two is really what's going to help our progress moving forward as we discuss this and look to do a root cause analysis of how we got here and how we can improve on where we want to go.
Just to add one comment, and obviously I'm not a clinician, but from the legal perspective, when you talk about addiction, we don't criminalize addiction. You criminalize conduct. So it could be a crime, say, to possess heroin or to sell heroin or to buy heroin, say, or to divert prescription opioids to an illegal and illicit use. There's no crime in being, quote-unquote, addicted, and the Supreme Court spoke on this quite some time ago and struck down various laws that used to exist that would attempt to criminalize, in the guise of vagrancy and alcoholism, what have you. And I think that when we're talking about resources, looking at addiction more as a medical, clinical problem that these folks have the knowledge to deal with, rather than as a law enforcement issue, I think ultimately is a better use of society's resources.
Great. And just to add on to the clinical side of it, so if you look at the psychiatric definition of addiction, it is an uncontrolled behavior that impacts ability to function in both home and work environments. It's not a moral issue. It's not a matter of not having the willpower to overcome. But as Dr. Baker mentioned, it really is a chronic disease that we must consider just as diabetes and heart disease are both chronic diseases. And looking at the science of addiction, it is a disease of the brain that impacts the communication between various areas of the brain. For instance, the prefrontal cortex controls your ability to judge and make decisions. The limbic area of the brain controls your ability to produce emotions. And then there's also the reward center in the brain. And the communication between these different areas are impacted in patients who experience addiction. There's dysfunction there. In addition, looking at the science of addiction, there's dopamine release when patients take opioids. And over time, it takes more and more of the opioid dosing to produce the same level of dopamine release in the body. So you can really think about the science behind it, the medicine behind it, and that it is a chronic disease.
Great. Thank you very much. It really sets a great foundation for the rest of our discussion this morning. So is there, we hear in the news, we read in the papers about an opioid crisis, both here in New Jersey and nationally. Is there really an opioid crisis, and how bad is it?
Maybe I could start from the legal perspective. And I was talking to some of the folks at the breakfast. When we talk about something as a crisis, I kind of think of myself as the character from Animal Farm, the Donkey Benjamin. I've been around a long time and have seen a lot of things. And, since I was a prosecutor back in the 80s, prescription drug diversion and these sort of things was always out there and always an issue. This is not something that's happened. And I think what's going on more is that we're just more aware of things now. I mean, now you keep statistics, and the CDC publishes statistics on the number of overdose deaths and these sort of things, and you're seeing it more in the news cycle. So I suppose in that sense it's a crisis, but this has been a problem that's been around for a very, very long time. And I think as a lawyer, what bothers me is that, you you only have resources devoted to something or attention paid to it, when it makes the cable news cycle and people start seeing it on TV. So, yes, there's a crisis, but I'm not so sure if it's any more prevalent or less prevalent than it was 10 years ago or 15 years ago or 20 years ago. These folks probably know better than me on that score.
Yeah, I'll comment. I think the statistics show, I want to answer about this notion of a crisis as well as just sort of what the stats are. And I think the stats are that there are more deaths now than there have been recently. But it's important to understand it in context. And I think, Bill, are you Bill or William? I don't know.
Bill's fine.
Bill. Bill mentioned this fifth vital sign. How did we get here? This all kind of started in 1995, where there was this recognition that pain was being undertreated. And everybody piled into it, from professional societies, the American Pain Society, to politicians, and it's always great when we politicize medicine. And this notion of crisis, we run the risk right now of overreacting in the other direction. And we've got to be cautious about that, because there are patients who have real pain. Morphine and their equivalent drug or similar drugs are very effective drugs in the appropriate situation. So the way we got from 1995 to 2017-18 with more deaths, there are more deaths. It is a problem. We ought to deal with it, but we shouldn't overreact. We shouldn't have, and I don't know anybody's politics, but I think our president is saying things like death penalty for, it's just a hysteria that isn't helpful to the conversation. And so I think that this group, being more immersed in it, you guys, some of you are employers, this is a problem that people have. We can manage it as a society, but we should just do it in a measured way. We should trust the clinicians who are working in a multidisciplinary way with their patients, and we all can support this without being unduly sensitive. We need to set limits as well. And so it's a crisis, but we should be calm, because the cooler heads will prevail.
Yeah. And to build on what Dr. Bryt said, one of the things that we have to be very careful of is fear. So many patients or so many people that have an addiction issue are terrified to seek treatment. And the more we criminalize it and demonize it, the less likely they are to seek treatment. We deal with a lot of EAPs, we deal with healthcare professionals, and virtually everyone I talk to, their first thought is, I'm scared to death to go seek treatment because I'm going to lose my job, I'm going to lose everything. And they're really, in some professions, they're starting to change how they approach addictions, and it's not automatically, all right, you're fired, get out of here. We'll seek treatment, we'll find a way to get you back in, and we'll reintegrate you to the workforce. Healthcare providers have really kind of led the future with that, in that there are programs where licensed professionals can seek treatment, have their license shielded, and return to work. And I think there's more industries and multiple professions need to start taking a look at that. And as the panel has said, really take a look at this as a disease. You're not a bad person, you're not a criminal, you're somebody with a problem. If a diabetic eats a donut, we don't look down on them. So if a person has an addiction or somebody in recovery relapses, we need to treat it as a medical problem, not as a failure of a personal failure.
I would say we do look down on the diabetic who eats a donut, but
as long as it's only one.
And I think in consistency with what everybody said, hyperbole is really dangerous when you're talking about something with this magnitude, and complex problems don't have simple solutions. So anybody that says, putting a sticker on a prescription or education, I think we have to tackle this with a multi-pronged approach with multiple stakeholders. There's no easy answer, but it's important to understand how we got here. And pain is real, and we don't want to go to one, end of the pendulum. But we also should ask ourselves why, when the U.S. represents 5% of the world's population, why does it have 80% of all the opioid prescriptions? There's pain all over the world. There's doctors all over the world. There's pharmaceutical companies all over the world. Granted, we're one of the only nations where pharmaceutical companies can take out $1 million ads on television. That's banned in most Western and other parts of the world. So it's a systems problem, and then it funnels down to the clinicians and the patients. And I think, involving the right stakeholders is critical, and relying on science is important. And I liken this to 20 years ago when there was a lot of misinformation about vaccines that came out with false studies, and what downstream issues that created with outbreaks in measles in the U.S., and vaccination rates plummeted to 60 to 70% in the 90s to early 2000s based on misinformation and people relying purely on the media. And, the onus is on physicians and clinicians to properly educate and communicate to their patients, as hard and challenging as that might be, to undo all the misinformation out there. And now it's a lot more challenging than the 90s because you have social media, you have 24-hour content of information hitting you constantly. So our challenge is extremely important, and all healthcare people are committed to the quadruple aim, which is improved quality, which is outcomes, improved access at a lower cost, and taking care of the population. And we really can't do that if there isn't trust, if there isn't good communication, and you're not relying on evidence and best practices. So I just want everybody to use facts in our approach and communicate that to providers, pharmaceutical companies, athletic trainers at all ages, so we can, get where we want in the short term and long term.
Yes, and I'll just add that, I think we all can agree that this is a highly prevalent problem. 1 in 4 prescriptions for opioids can lead to addiction. Over 20 million Americans suffer from substance use disorder. And then in looking to the workplace, it has been found that in areas of increased opioid use, there's also concurrently a decreased labor force present in those geographic regions. So, but I think so. We all know that it is an issue, but as clinicians, and has been mentioned on this panel, it is in our approach that we take to assist these patients from a multidisciplinary methodology and to help them in both the mental and physical components of addiction and treating it as a disease.
So thank you very much, Dr. Letourneau, and I'd like to pick up on that last comment. And so if you're an employee who has a substance use disorder, and you want to really start that journey of recovery, what are some of the things that are kind of in your toolbox that can help you, as an employee to support your recovery, as well as to maintain your employment as well?
I'll take a stab. And it relates to some of the earlier comments. This is not just a medical problem. This is a social problem that we have going on. And, physicians have a large role in that, but physicians see a patient 30 minutes, 45 minutes, maybe it's every month, maybe it's every 3 months. There are a lot of minutes in between. And so I think this is an employer conference to a great extent. And so our families and the employers play a big role. And so what the employee can do depends a lot upon what the employer has done. And I think to Dr. Baker's point and to many others, this is, to not just make it a criminal offense or to make it harder to admit that you have a problem makes this worse. And so both families and employers, EAP programs have been mentioned here, are good ways for employees to go out and get help. But it can't end with the medical profession because most of the minutes are spent with the family, not with the medical profession. So there are various ways that you can help the patient when they're not seeing the physician, sort of outside of the physician office on this chronic disease. There are concepts of case managers. As an insurer, we have case managers, but even a case manager. You make a phone call, you maybe visit them a small amount of time. You need a broad support group. I think different treatments work better for some patients than others. So AA is very effective for 20% of people. And so, but for those 20%, it's the best thing they've ever had because it works for them. I know you're a mental health professional, you're sort of nodding. And so we can't have this one-size-fits-all on mental health issues because we're not all the same. And so I think the employees can be helped by the context, and we can invite ourselves to speak up about it.
And to build on that, I think the human resources departments in companies and the EAPs, the employee assistance programs, are really the first line of defense and the first go-to. I think over the past few years, EAPs and HR has really started to recognize that this is more of a medical issue than it is a criminal or a disciplinary issue. And we work with a lot of EAPs and a lot of HR departments to get people into treatment and into recovery and hopefully to return to work. Some of the complicated areas that HR can help with is a lot of people don't think that they can get disability, they can get FMLA if they have an addiction problem, but they can. It's very complicated, and anybody that tries to go that route is going to need some assistance, and HR can be helpful with it. And it really depends on HR departments having well thought out policies and be more sensitive to their employees. Because let's face it, these days bringing a new employee on is a very expensive proposition. Like I said, we work with a lot of hospitals. Bringing a new nurse on could be $30,000 to $50,000. So if you have a proven person who has developed an addiction problem, but is otherwise a great employee, investing that time and effort into getting them into recovery and returning them to work is not only ethically right. It's a good investment in your business.
It could be a double-edged sword, though. I represent a lot of healthcare providers, hospitals, nursing homes, what have you. And what I have seen anecdotally is you'll have people that have access, then they have to have a substance abuse problem themselves, be they a nurse, a physician. And what happens I think that what Bill's talking about, if the employee doesn't make that leap and seek assistance, it becomes problematic, because if I now have a nurse that's, figured out how to divert things out of the Pyxis machines and things like that, and they've stolen medications, now the employer is, kind of in a catch-22, because if they know to have someone that's committed a criminal act, they really can't let them continue to perform their duties. So it really is, from a legal perspective, if the employee can't take the initiative to take advantage of some of the things Bill's talking about, I think for a lot of employers your hands may be tied, because the last thing you want is to read in the newspaper that you ignored somebody pilfering medications or engaging in criminality and kept them on board providing care to the patients. And that's the difficulty, I think, in the balance you have to have as an employer. You want to make programs available, you want to make assistance available, but once someone's crossed the line into criminality, then it becomes very problematic for you to keep that person on board to prevent yourself from being exposed to liability.
Yeah, and I just want to add, overall, getting back to your original question, you must remember that, being healthy, health and wellness is a prerequisite to be a full participant in the labor market and in public life. So, everything starts from that, and that was the theme of the transition team. And I want to allude to the point made recently about, the fact that clinicians and patients do spend a very small proportion of time together. Fortunately, organizations like ours and others have the infrastructure and resources to acknowledge that. And once the patient leaves, it shouldn't end there. So if you have the resources and the ability to reinvest in your infrastructure, you can hire more case managers, more social workers, more clinical pharmacists, and understand that the mental health issue, the comorbidities associated with it, there are a lot of psychosocial aspects to that. So that's why we assign a case manager to follow these patients when they leave our office, to call them every 2 to 3 days. We've identified, using healthcare and technology, using the prescription monitoring program, or if our mental health team or pain management team has access to the primary care notes, to avoid patients going to different providers and forcing patients to sign a doctor-patient contract. And if they break that contract, unfortunately, they can no longer remain patients. Not prescribing more than 6 pain pills at the first visit. Some of our physicians don't prescribe any pain pills at the first visit. They want to establish a relationship, do a urine toxicology, make sure the patient is on board. So all those things, because in the last 15 years, EHR has become required. So if you don't take advantage of the technology available to better understand your patients and make better decisions, I think you're doing a disservice to the American population. And that's one of the unintended consequences of the new technology out there. It affords clinicians and systems a lot more information to make better decisions on how to manage patients and learn more about them, especially for drug-seeking patients that might not be so forthcoming. So that's very important, I think, to remember in the long run.
To Dr. Baker's point, the number one barrier to achieving recovery in workers with chronic pain has been found to be psychosocial issues. And so really we do need to utilize a model in treating these patients that addresses the biopsychosocial aspects of care. And studies have proven that if that model of care is used in patients with chronic pain, that they would experience less musculoskeletal pain, less mental health symptom severity, and return to function faster. So I think just to all these points that have been mentioned up here, it is really a multidisciplinary approach that's needed addressing those three different areas.
Could I add to Jack's point? So, it might sound to you, and I'm going to speak for people who I don't know particularly well, I don't think we're saying that you shouldn't set limits and we should soft pedal with people. We need to set good limits for these people because they need that help. And I think that was sort of Jack's point. It's not necessarily criminal limits, just limits on either what number of pills that you give, or what's acceptable in the workplace. So we're not saying to be, oh my God, walk on eggshells. This is a set limits, support, but make people accountable for their own actions. You need all of that combined.
I think that's a good point, Dr. Bryt, is that individuals have a responsibility themselves as well in terms of their recovery and success in the workplace. So a number of you, particularly Dr. Baker and Dr. Bryt, you talked about pain and the utilization of the prevalence of opioids in the treatment of pain here in the United States. Can you talk a little bit about the alternatives to managing pain and alternatives to using opioids?
I'll jump on that. I mean, if you look at the multidisciplinary approach, I think all healthcare outcomes and costs start with the primary care physician. So the emergency room will get a lot of attention, surgeons will get a lot of attention, pain management doctors. But if you look at the bulk of prescriptions, I don't want to jump to fentanyl, but that's the one that's getting a lot of news because of the potency compared to regular opioids. In the state of New Jersey, 80% of all fentanyl prescriptions were by internal medicine and family practice doctors. Okay? So they're the ones that the patient has the most trust with. They're the ones that control and see the patients most frequently and determine if a patient is referred to a certain specialist or sent to a hospital. So our focus is basically educating our primary care doctors, making sure patients have access to primary care doctors, and making sure the primary care team integrates seamlessly with our mental health team, our rheumatologic team, and our pain management team. So the first thing is coming up with the appropriate diagnosis. You can't have a good plan if you don't make the right diagnosis. So you have to come up with the right diagnosis, and that obviously differs depending on the population. Number two, you have to understand the cultural and socioeconomic barriers to care. Healthcare is regional, even in New Jersey. Healthcare in Camden is different than it is in Bergen County. Camden has some of the highest asthma rates in the nation. So you have to understand, and just an example unrelated, that there are socioeconomic and cultural barriers, and if the physician or nurse practitioner is not in tune with that, it's going to affect the care that the patient receives. So you have to be culturally sensitive to the care you're delivering, and you have to look for alternative options of pain treatment. You have to educate new physicians that trained during that period of time where pain was a sixth vital sign, and you have to educate all people that are stakeholders in the care that there is alternatives. There are NSAIDs, which are strong anti-inflammatories. There is there's physical therapy. And if you do go to opioids, it shouldn't be the first line treatment, and you shouldn't dispense, a month's worth of supply for somebody who had surgery or somebody who had a fall. You should do it in a very tiered approach, and you should monitor that patient closely, and you should extensively counsel them, especially if it's a first-time user, on the side effects and the risk of addiction. It's first do no harm as a physician. So if you're not fully transparent and you're not effectively communicating, then you're not doing your job as a clinician. So I think the patient must be aware of the risks and benefits of any treatment, and I think we're seeing a lot more of that, Valerie, now. Patients are more proactive. They're more involved in their care. They expect more information and more transparency. And then patients that do get narcotics or opioids, you need to monitor them very closely. And we rarely dispense it in the pediatric population. It's extremely rare. And even our adult population is monitored very closely by the clinicians and the team that's responsible for that. And just to get back to the point about, patients being involved in their care, my biggest fear and concern, and I'll talk about New Jersey, is out of the 9 million residents, 1.8 million are Medicaid. Okay, and 500,000 of those 1.8 million were added under the ACA. So that's almost 2 million residents out of 9 million who are Medicaid. So opioids doesn't discriminate if you're rich or poor. So it's those 2 million people that we need to make sure have access to primary care physicians, access to mental health specialists, and access to the right resources. Because those are, the most vulnerable population. And getting more primary care doctors to accept Medicaid, getting more mental health specialists to accept Medicaid, will be great because you need a continuity of care plan. You shouldn't be getting care for addiction or pain in an emergency room. That's called fragmented and fractured care. You need integrated and continuity of care, and that's why we need to really address that and make sure there's enough resources and funding, and I believe this administration is committed to doing that.
I'll add by just putting some facts out. There are very good studies that show that Tylenol and Advil combined is a very, very effective pain reliever. From a pure pain relieving point of view, Tylenol and Advil together, and you can take them together, are as powerful, and I'm not talking for a car accident here with multiple fractures, as powerful as an opioid. Now, what they don't do is they don't affect the mental state. And what opioids do is they help with pain a little bit, not as well as Tylenol and Advil together, but they really affect the mental state. So one, Tylenol and Advil is very effective. You should just know that. 2% of people in a commercial population, 1 to 2%, are going to be persistent opioid users, meaning they'll have moved to 6 months, beyond 90 days of usage of an opioid. In a workers' comp population, it's going to be north of 10%. And there are some populations where it's significantly greater than that when you've got people who are out of work and in the workers' comp system. And so this issue of pain, we're jumping very quickly to opioids, and then we're jumping to Omar's point, to giving too many pills at once and sometimes giving long-acting when short-acting is necessary. So we have the tools, in addition to non-pill tools, to do a better job with pain than we have today. But getting back to something we said earlier, we shouldn't just cut off opioids. They've got a role. They really, really help patients, certainly in cancer patients, certainly in multiple trauma patients. They ease the burden of pain, even if they don't actually change the pain response as much as some other drugs.
Absolutely agree with those points. I think it's important to recognize that opioids are not intended to be a long-term pain relief therapy. Studies have not demonstrated efficacy for long-term use of opioids beyond 16 weeks. And as has been mentioned today on the panel, there are alternative pain medications out there. If you look at the pain algorithms for nociceptive pain, which is your musculoskeletal pain, and also for neuropathic pain, which affects nerves, there are multiple other agents which are recommended as first and second line treatments before you move to opioids. And those can include nonsteroidal anti-inflammatories, acetaminophen, antidepressants, anti-epileptics, depending on the pain type. And so we really should be moving through that pain algorithm and looking to these alternative pain medications prior to attempting opioids. When opioids are attempted, as has also been mentioned, education is very important. Giving physicians the resources to look at evidence-based practices, guidelines, such as those provided by the CDC. It has been shown in studies that physicians who prescribe more opioids tend to have trained at lower-ranked academic institutions, which just goes to show that we really need to educate and provide those resources and look at setting some of those limits and thresholds at which overdose increases. Ways in which to increase access to education can include technology. There are, predictive data models out there. I know it's something that we're working on to identify risk factors for patients early on, to look to intervene and to say we need to intervene early in these patients and they may experience delayed recovery. And also, as a last point, I think the overarching message is that this needs to be a multidisciplinary approach. This has been mentioned multiple times today, where we have a multimodal team which consists of a pain management specialist, a psychiatrist, a psychologist, a social worker, all working together to explore other therapies, which can include psychotherapy. We also mentioned physical therapy, occupational, as well as looking to social factors such as family stressors, occupational stressors, to see how we can intervene.
And from a treatment perspective, so much of what we do really focuses on behavior modification. So many of our patients arrive with the idea that, if I have a pain, I have to take a pill. If I'm anxious, I have to take a pill. Whatever my problem is, I have to take a pill. We call it hand-to-mouth disease. And it's really, we work with people with the whole biopsychosocial wraparound, to understand that there are other ways to deal with pain, to deal with anxiety. We have a very active wellness department where people learn about acupuncture, yoga, massage, other ways to deal with pain and anxiety. And it really it takes some time to get away from that because so many of these people have spent their lives wrapped up in, whatever's wrong, I could take a pill and it'll fix it. And it really does, there needs to be a change in behavior and a change to approach to how you deal with pain and how you deal with other mental health problems and other issues you have in your life.
Thank you. So in part, I think as we look at how we address this opioid epidemic, I think it's also important to understand the federal landscape as it pertains to the enforcement of laws. So, Mr. Wenik, I don't know if you can speak to a little bit about what the U.S. Department of Justice, what steps they've taken to address this opioid epidemic.
Sure. So this kind of circles back to the question earlier, are we in a so-called crisis? And bureaucrats and politicians, be they what they may, respond to what's in the cable news cycle. So now that we're in a quote-unquote crisis, all kinds of task forces are being set up. So Attorney General Sessions announced that he created a separate unit with more than a dozen prosecutors just to focus on prosecuting opioid diversion cases and trafficking cases and this sort of thing. That was a few months back. He just set up another task force and hired some more people for more prosecutions. I think we heard the president yesterday say he wants the death penalty for traffickers. And, in my mind, it's kind of like deja vu all over again. To take a, law enforcement draconian approach, as I said, I'm kind of like Benjamin the Donkey in Animal Farm. I've been around a long time. And, I vividly remember the war on drugs that I was a part of when I was a young prosecutor. And all that really has produced is a multi-billion-dollar private correctional industry and with the mass incarceration of tens and tens of thousands of people. And we used to measure success by the street value of heroin and cocaine when I was a prosecutor. The notion was if it was getting more expensive with all our efforts, that means it's working. It's getting harder to get. And I remember at the height of all this, it was actually cheaper to get cocaine and heroin. I think you actually get heroin cheaper now than you could buy the illicit pills that are diverted from the prescription marketplace. So unfortunately, we're getting a lot more of the same, of the law enforcement approach to this problem. More resources. I heard that the New Jersey U.S. Attorney's Office has also created a specific opioid unit to prosecute these sort of cases. And I'm not convinced that this is the way to spend our resources and the way to approach the problem. I think, as these folks to my left and right have indicated, it really is more of a clinical, medical, psychosocial, mental health issues that we should be addressing with other tools.
Yeah, just not on the criminal side, but just to jump on that, I think there's also tremendous opportunity now to demonstrate corporate responsibility and how you can reinvest into the community. So besides delivering great care, there's a lot of opportunities now to basically take full advantage of and kind of fill in the gaps where maybe the federal, state, and local systems are not helping. And a prime example of that just happened here in the state of New Jersey, where the largest insurer, Horizon Blue Cross, that insures about half of the state's population, got a huge federal tax credit from Washington, D.C., and they took over nearly, I think it was $100 to $200 million of that profit and said they were going to reinvest that into the opioid epidemic in New Jersey. So I think that's just a good example of, private, not-for-profit, and corporations kind of also doing their part. Not only healthcare organizations like Horizon Blue Cross, but other organizations also have that opportunity. So that shows some sign of optimism and hope that there's ways to work within the legal structure, and there's a lot of opportunity for us to have a tremendous impact at New Jersey's level.
Could I comment on the law piece? And, at the end of the day, this is a public health issue. And public health is sort of a loose term that really encompasses all of the things we've been talking about here. If you think about tobacco, which, doctors used to smoke in the OR, And somewhere along the way, science identified, actually, tobacco causes cancer. It took us 30 years to go from 45% of people smoking to now sub 20% of people smoking. That happens because generally there's a change in public opinion about stuff. And what needs to happen now is not a violent jerk to one side or to the other, but a change in public opinion to so many of the things we talked about here, this biopsychosocial, how do you limit prescriptions appropriately, how do you enable them appropriately. It takes time, it takes employers, it takes families, it takes governments, it takes politicians, and all of us in this room should do, I believe, what we can to just have people take measured and consistent approaches to this. We'll be better off for it.
One last comment on the law enforcement issues. One of the things that I think has made it very difficult for federal, state, local law enforcement is the internet. Every day I learn about some new drug or some new substance you can buy on the internet, whether it's some sort of a derivative of benzodiazepine, phenibut, cannabinoids, and a lot of these are basically unregulated, so that even if you are caught with them, there's not a lot federally you can do or legally you can do. Like I said, almost every day I learn about some new substance that you can order from Estonia or some foreign country. So there's huge challenges even beyond the opioids, and you know, from a legal standpoint, the law enforcement, I don't envy the position they're in, trying to figure out and stay ahead of all the different things that are out there and available to people who want to purchase them.
Thank you. I certainly do appreciate the comments that you've made, especially in demonstrating that it's an issue that, that really takes a multifaceted approach to address. It's not just it's not just clinicians and practitioners, but it really is a multifaceted approach. So I'd like us to talk a little bit about New Jersey and what some of New Jersey's efforts have been to address this opioid epidemic. I know, Dr. Baker, as you mentioned, you were on Governor Murphy's healthcare transition advisory committee and actually co-chaired it. But some of the others here on this panel as well have begun to touch on a little bit, some of the things that are happening here in New Jersey, both legislatively and otherwise.
Yeah, I'll just speak, on from a macro level. Obviously, even Governor Christie was pretty committed to the opioid epidemic. So Governor Murphy's taking over a pretty good infrastructure and culture within the Department of Health, which Valerie's been in for over a decade. So we have the right people in place, we have the right infrastructure in place, and we have the right ideas in place to really be a leader in this throughout the nation and make our protocol something that's scalable and something that's admirable. But the main issues are really, we recognize, on the state level that the state agencies are kind of fragmented. So we want more multi-agency cooperation and integration between the Department of Health, the Department of Banking and Insurance, and Human Health Services. And I've already seen some promising integration and collaboration between multi-agencies for us to achieve all of our goals on the state level. I already alluded to about 2 million out of the 9 million residents of the state being covered under Medicaid. So that's a huge initiative for the state and the governor to make sure that the Medicaid population has the same access, same quality as the commercially insured population. Because, a quote that was said 50 years ago, which kind of penetrated my brain and was my impetus for access and quality, was, of all the injustices in this world, inequality in healthcare is the most shocking and inhumane. And luckily, Phil Murphy believes that healthcare is a privilege, a right, not a privilege. And that was Dr. Martin Luther King Jr. more than 50 years ago, and it still applies today, in my opinion. And other things are basically integrating mental health and primary care, which we alluded to. That's very important. And also superseding and integrating addiction services on top of that. Reform, obviously we need reform at the state level and working with the correct stakeholders to get the proper reform. Obviously education of clinicians and patients so everybody's on the same page in order to get to the best outcomes. And basically ending the regulatory logjam that's in Trenton right now to help get more centers licensed for intensive outpatient therapy and addiction, and get the right people, the right funding they need, kind of cutting through the bureaucracy and the red tape, because we don't have a lot of time. We need to act quickly, and we need to get people the right help that they need all people of this state.
So there are two basic things that are going on in New Jersey. One is the quote-unquote creation of laws, and the other is, as Omar alluded to, the Dr. Baker, the increase in resources. And as a lawyer, I suppose I should be happy if there's more laws because it's more business ultimately for me. But I think as a society, the first reaction is that, quote, ought to be a law to address whatever problem we have. So there was some legislation passed towards the tail end of Governor Christie's administration, which directly addresses what physicians can and should do with regard to opioids. Probably the most high-profile provision was a 5-day limit of prescribing for acute pain. That should be just a 5-day supply limit for the initial supply. And then there was other statutory provisions requiring physicians to give certain disclosures to their patients, certain warnings, certain limits on subsequent prescriptions, these sort of things. And, when I talk to my clients, clinicians really resent when bureaucrats and legislators pass laws telling them what they can or cannot do. I think most clinicians feel, there may be extenuating circumstances why I want to give somebody more than a 5-day supply. There may be extenuating circumstances where I want to tell somebody something different that's what's in these legislative guidelines. So I'm not so sure the enacting new legislation is really the way to go. I think that, the standard of care and, to your point, more education and training is really the way to go with physicians and clinicians and to educate them maybe better about what the downsides and risks of opioids are. On the flip side, as far as more resources, I think we could always use more resources, but again, I love how government creates acronyms. So we have something called now, that just came out last month, New Jersey Cares, which actually stands for New Jersey Coordinator of Addiction Response and Enforcement Strategies. So we've created yet another sub-entity within the Attorney General's office to assign more people to supposedly solve the opioid problem. And again, I don't know personally if giving more resources to the government is the way to go. I think maybe to give more resources to make sure, to your point, that people that have Medicaid can have more funding to get the services and the treatment that they need, rather than establish another government team or task force, or to have more education and training out there. But the route that, unfortunately, in my mind, we seem to be headed down is more laws and more government task forces and agencies being set up to supposedly address the problem, rather than, in my view, let the professionals handle this, let the clinicians and the healthcare plans provide the coverage and the range of treatments people need without government trying to dictate what's proper and what isn't.
Yes, completely agree. And to follow up on that, on the limitations of legislation resources, there really are two sides to every coin. In looking at the specific legislation in New Jersey, as just mentioned, there is the 5-day prescription limit. On the one hand, that allows physicians to meet more frequently with the patient to reassess pain and to avoid these long-term opioid prescriptions. But on the other hand, you have to think about the patients who may have socioeconomic barriers that prevent them from attending frequent appointments with their physician. That could lead to untreated pain, that could then lead to more disability and higher incurred costs within the system. In addition, there's legislation surrounding prescription drug monitoring programs. I'm sure a lot of the clinicians here may have experience with that, and it does allow you to look to see if the patient exhibits drug-seeking behavior in that state and has filled prescriptions in the same state for the same type of script. However, there's limitations with looking across state lines, so you may not know if the patient comes to you in New Jersey, he or she may have already gone to New York. And another caveat to think of as well, when these patients who do have this addiction to opioid pain relievers are unable to get that prescription, they may turn to street drugs, such as heroin. And over 80% of heroin users at one point initiated their use of opioids with a prescription. So these are just important aspects to think about from the legislation side. From the resources side, I also agree that it's difficult when just giving these resources to the states and not having it trickle down to the clinicians and individuals who can allocate the resources. If you look at the 21st Century CARES Act, which was enacted at the end of last year, $1 billion was promised over the course of the next 2 years to give to states. And I know that they've been looking recently at how this funding has been spent, and a lot of the funding has gone unspent by the states as of now. And so it's just a matter of how, or if we do have the resources, how are we going to properly allocate them and use them correctly?
To expand on treatment a little bit, there is a lot of money flowing into various options for treatment. One of the things that I've heard a lot about here recently is medication-assisted treatment, which uses agents such as extended-release naltrexone, buprenorphine. And from a harm reduction standpoint, it does have some applicability. But I think the thing that we need to do is, just as that pendulum we talked about earlier, swinging one way or the other, there's no single solution that's going to fix everyone and be the magic bullet for treating addictions. So we need to have that multidisciplinary, multifaceted approach because no single solution works for everyone. And I think right now there's a lot of government agencies and a lot of health systems and that all looking for that magic bullet that just doesn't exist. So, I think a thoughtful process to get to what we're going to do for treatment going forward and making sure we're making the right choices for the right treatment for patients is going to be very important as we try and tackle this crisis.
Yeah, I don't have much to add about the state of New Jersey, but since I work in multiple states, what's going on in Connecticut, New York, New Jersey, other states around, it's really very similar. Everything we just talked about here is really happening in each state. And so, my view would be that politicians and laws can help create the environment that is sort of the public health environment that changes people's opinion. And then it's ultimately the tactical things we do, whether it's Riverside Medical Group with a case manager calling 3 days after a visit, very, very important, or an employer with an EAP program, or an employer working with their PBM, their pharmacy benefit manager, to understand who's taking what medications, because you're paying for that, at least in today's healthcare system, Medicaid aside. And then how might you be able to limit those prescriptions in some specific instances? It's hard to manage something other than just public opinion at the legislative level. And I think it's important to do that to some extent. Not much more to add.
Yeah, if I could just add, I think we have to be consciously proactive to not try to cast blame to any certain population. It makes headlines, and that goes with the issue when you have X dollars of resources. I think even law enforcement and legal professionals would agree the majority of those resources in a healthcare dilemma or a crisis should be shifted to the patients and those in need, not to law enforcement officials. It's great to say drug dealers should get the death penalty because, again, it's a headline. Doctors have good intentions. The majority, 99.99% of doctors go into medicine to help people. When you read in the paper that 4 or 5 doctors, I think, were arrested last week, those are not doctors. Those are legal drug dealers that should not be practicing medicine. And that is an outlier and a huge minority of the millions of doctors who practice medicine in this country. So we need to help the physicians, re-educate them, and empower them and give them the right tools. And we need to shuffle as much resources to the patients that are currently battling addiction. And we have to come up with a short-term and long-term plan to prevent this from happening and prevent more people getting on opioids. And how do we address pain moving forward? And let's start in medical schools, let's start in nursing schools, let's start with surgeons, and let's start with the new generation of people that are coming out.
Thank you. And I'd like to offer those comments a little bit in that in addressing this opioid epidemic, I think it's important to be able to know and recognize and pinpoint those intervention services that are having a positive impact as it pertains to, where the rubber hits the road and those who have a substance use disorder. And so I just wanted to know if you could speak a little bit to the use of data analytics and technology to help us to further understand, where we're making positive strides and where potentially we may need to refocus some of our efforts.
Yeah, I'll just talk briefly, and then anyone else can jump in. Like I alluded to, the High Tech Act that was passed by Congress about 8-10 years ago now that required groups in the U.S. to basically subsidize and go on electronic health records, although a lot of doctors don't like going into a room with a computer. Like I mentioned, the unintended consequences is it allowed for population health to exist. It allowed for us to study our patients. It allowed us to get data. But getting data is really the easy part. It's analyzing the data and then communicating that data to practitioners to change behaviors. That's really the challenge. What we do at Riverside is we have a team-based approach, like I mentioned, and it all starts with a primary care doctor. But since we added a mental health division and a pain management division about 30 months ago, we now have the lowest prescribing rates of narcotics in the entire northern half of the state for the 250,000 patients we represent. And that's all due to having a team-based approach, having access, accepting all insurances, commercial and Medicaid, and using our data to better understand our patients and communicate clearly and consistently. So it's an easy plan, but it requires a lot of resources. It requires a cultural shift, and it requires a buy-in from patients and providers to do that. And I would be remiss if I didn't give a shout-out to our Director of Mental Health, who basically spearheaded this. And in our second year, we've cared for about 35,000 outpatient patients, unique, in the northern half of the state. It's also her birthday, so my sister, Dr. Bahar,
Happy birthday,
is what allowed us to accomplish this. But, I think data and technology is super important if you know how to use it and how to involve the patients in kind of being more proactive in their care.
So I'll give a simple one because it's hard to remember all the facts that we're throwing out here. So I've understood this is a forum of employers. That's it's oriented towards. The one thing you can do leaving here is go and talk to your pharmacy benefit manager and find out who among the employees that you provide insurance for are using opiates on a chronic basis. Don't worry about the 7 days. Worry about the 90 days and the 180 days, and then see, do you have anything in place for that? That'd be the one thing that you can do within your population, in addition to everything that physicians are doing, and I think most groups, I don't know the Riverside Medical Group particularly, but what is described is, I think, the right approach to it. We still live in a fee-for-service world where most doctors get paid to take care of a patient and do a service or procedure right now. They're not paid to do something when the patient has left the office. And so, by and large, even in 2018, you're mostly getting care at the time of the encounter. But you as the employer, these are your employees. You can go in and look at your data that you're paying for and figure out, is there something you can do? We insurers offer programs oriented towards persistent opiate users. Physicians have ways to manage them. Behavioral health providers are great opportunities to channel patients who need them to get care. But what you can do is look at your own data.
Yes, and speaking to the technology and the data aspect of it, it's really important that we start to develop these risk tools and get them into the hands of clinicians where we can fully deploy their use. As mentioned earlier, our company is currently developing, using claims data, a predictive risk model that can be used in those with substance use disorder and injured workers to intervene early and to predict the patients who are going to have and experience delayed recovery. So moving in that direction, as I know other companies are as well, really is the future. I just attended the HIMSS conference, the Health Technology Conference the other week, and you can just see that the integration of health and technology is really going to facilitate some of these changes that need to be made within healthcare.
So as a lawyer, the one thing I would say about this whole data analytics, what my frustration is now that I'm on the defense side and defending clinicians and hospitals is, in my view, it should only be the starting point. Over and over again, I hear the same scenario. My client will get a letter that we did some data analysis, and you're the number one prescriber of X. So we're suspending your prescription privileges pending further review. Or putting you, if it can be a health plan, we're putting you on prepayment review because you're the number one treater of this and the number one user of this CPT code. And again, for sure, you should be analyzing trends and things that stand out, but that, to me, that's the starting point. Maybe there's something about the patient population that this particular clinician or this particular facility is treating that justifies the treatments that they're giving. It justifies what's going on. And I see too often that the data analytics is used as a shortcut rather than have, say, a clinician do a quality review or a appropriate utilization review of something. It's just spit out from a computer. You get a letter generated by a computer, and then now I have to intervene and say, well, wait a minute, did anyone actually look at this? Did anyone actually pick a sample of the patient charts and do some sort of audit to see if what was done was being appropriate? And that, I think, is the data of analytics, this tendency that I see that it's the be-all and end-all and becomes not the starting point, but the beginning, middle, and end of the inquiry. I think that, yes, you spot a trend or an issue, but then you need some sort of professional clinician to review the circumstance and opine on it before we take action. That's the other side to this, is I see the quick suspension of providers and institutions so quickly, just based on data analytics, without any investigation whatsoever.
Yeah, I'll support that just as an anecdote. So one of the privileges or burdens is that health insurance companies look at provider credentialing applications. Every 3 years, you've got to look at all the provider applications. And what I see in the different states is the way the different professional licensing societies are, in some cases, really, they're looking for some heads to hold up on a pike. And sometimes they do find the person who shouldn't be a physician who's just dealing drugs because they've got a prescription pad. But oftentimes you've got a physician who's done 2, 3, 5 prescriptions and it's not perfectly documented, and we just run off the rails trying to hang that person because we need somebody. And so we've got to be careful around all of that. That's more of an anecdote. The data is just a beginning. Knowing what the context is important.
Yeah, and I think the data is exponentially more important if the 4 key stakeholders are aligned and share the same mission and vision, and that's providers, patients, hospital systems, and payers. So those are the 4 key components of the healthcare delivery system. And if they're not all on the same page and hoping for the same outcomes, then there's going to be tremendous, counterproductivity. And that's the whole thing that was alluded to with data and value-based care as we move away from fee-for-service. But you can't have true value. Although to me, value-based care is a culture and a mindset regardless of how you're reimbursed for it. But as you start getting reimbursed for outcomes, I think that's going to ultimately impact this. But I don't think we can wait that long. But value-based care cannot be accomplished purely in my office alone. I can do a lot. I need the buy-in from the insurance companies. I need the involvement of hospital systems. And most importantly is the patient, and hopefully for patients who get well visits or see their doctor more frequently, then they should be incentivized by the payer. They should have their deductible taken down. They should have their out-of-pocket expenses given back to them. We should start motivating patients for well care. The current system in America is sick care. People go to the doctor when they're sick. If we start doing wellness visits and encourage mental and physical wellness, I think that'll have intangible benefits in 5, 10, 15 years.
Well, I have to say this has been really a wonderful discussion and panel. And so Dr. Baker, Dr. Bryt, Mr. Wenik, Dr. Letourneau, and Mr. Bruck, I thank you all so much for really sharing such great expertise and really about the disease of addiction, about recovery, about the national and local context of this opioid epidemic that we're in, and actually giving us some tools in the toolbox that we can use in terms of moving forward, whether it be individuals ourselves who are in recovery or as employers, what we can do to help to support individuals who have an addiction. So I really want to thank you all for really a wonderful dialogue this morning.
Thank you.
And so now has come to time for some questions of our panels.
My question to Dr. Bryt and Mr. Wenik. If my company, we looked in the prescription the employees use and we found 5 people use opioid on a regular basis, what is the next step? Is it legal to go to talk to them? Is not invasion of privacy? How to handle the situation?
I'll let the lawyer start with the is it illegal part.
To follow up with the patient, is what you're saying? The doctors exceeded the 5-day?
No, employees of the company.
Taking drugs inappropriately out of some store.
Sure. There's nothing to stop you from speaking to them about the situation and what happened, and if there's a legitimate explanation for it. In fact, you would be remiss if you didn't, if you took some precipitous action and didn't give the employee the chance to give his or her point of view. So yes, it's not an invasion of privacy. You've detected some sort of issue or question. You should confront the employee about it. That's what I advise my clients all the time.
Yeah, and I'll answer it slightly differently. So I advocated that you look at your data as a payer of healthcare services. I don't quite know your situation. And there it gets a little bit trickier because you're looking at someone's healthcare record and you're making some action based on some healthcare event. And so HIPAA looms large. But there are ways through this. You are entitled to look at that information. Certainly in this instance, there is, again, the approach of you're trying to do something with care. I do work with certain employers who have taken a very strong stance against their employees and their employee physicians who perpetuate long-term use of very, very high-dose opiates. And sometimes they engage administrative law judges in that situation. So there are ways through it. You need to be careful because we're in a litigious society. But I don't think it's a third rail. You don't have to stay away from it. This is all of our responsibility.
To your point, is if you're conducting a legitimate investigation, into a legitimate inquiry, you're not doing it just because you're curious. There are, exceptions under HIPAA to, that you're investigating something that may be, ultimately, possibly some inappropriate or even illegal conduct. So sure, you should follow up.
The other thing I would say is to make sure that you have policies that support what your decisions are. And if you do decide to confront an employee, that you have a plan on how to manage that. If they say, yes, I do have a problem, what should I do now? Be ready to refer them to your EAP, to refer them for treatment, because a lot of times when you do go to them, they may say, all right, yes, I do need help. What should I do?
I want to underscore something you said, which is this written policy concept is a very important protection for you. Just to have it written that says this is what I do when protects you in multiple instances. Not enough to say we all know what we do. That's very different from having it written. And it comes when someone comes in and audits or scrutinizes, having the written policy that's available to your employees if they want to read it is an important protection for you as the employer.
And it helps prevent charges of discrimination, because if you treat one person one way and someone else differently, you're opening yourself up to potential legal action.
Just Bill Lillis from the Partnership for Drug-Free New Jersey, and we help businesses set up and maintain their drug-free workplace policies. With grants from the state, we do it free of charge. But you, in management, employers, you guys have a great opportunity to do things in terms of prevention and education. So one quick story, a person in New Jersey, 27 years old, went through the normal pattern of behavior, legal prescription, finding drugs on the street, and then injecting heroin, comes back, recovery, gets back in the workplace, and a coworker offers her a Percocet. And that set her back in. So can we just make a comment? Can employers educate their employees about the distribution of medication, how improper that is? So that, I think, would be helpful to us in New Jersey.
Well, sure. There's a lot of initiatives about so-called safe disposal, that if you're done with your prescription, that it should be disposed of in a controlled manner. And I know some of the drugstore chains, I believe, have set up these drop boxes where you could safely dispose of your prescription. And we were talking, I forget if it was Bill I was talking to someone else, I'm not a clinician, but my understanding of we're talking about pain medications, it's not like an antibiotic where, you're supposed to do the entire course. Even if you feel better, you're supposed to finish that entire course. If you have no more pain, you're supposed to take it as needed. So, and part of that, I guess, is the clinician job to educate patients, but there are a lot of initiatives of safe disposal of excess prescription medications, and I believe that most of the drugstore chains now have facilities for that.
I'm talking about educating why was this employee not educated on the distribution of it? That was the mistake that caused this woman.
Well, I mean,
Can you put something in your policy or highlight it or educate our population that this behavior, and the number 4 drug used on the college level is Adderall. So our generations are moving from college into the workplace thinking it's okay to do this. So it's an important prevention aspect.
I think it's a clinical and a legal question. I mean, yes, I mean, people shouldn't be sharing medications, I think, as a general rule, as a common sense prospect. I don't think any, and I certainly think you could have it in a policy manual. I don't think realistically any prosecuting office is going to bring a case against someone for giving a couple of Percocets to a coworker, just as a matter for sources. But, as clinicians, I assume you'd counsel your patients, not to share medications and dispose of them properly.
I think relapse prevention is a huge issue. And it's probably something that most organizations have not really thought about because it's, a lot of times this is a dirty little secret. We don't want to talk about it. We don't want to think about it. And then when there's a problem, just as you said, there's a relapse. Anybody that has an addiction is in recovery. It's a chronic illness that they're going to deal with for the rest of their life. I think, a forward-thinking, ethical company should give that some thought and come up with a policy or give some thought to, if I'm going to send someone to treatment and then bring them back to reintroduce them to my workplace, I need to give some thought to policies like that. What happens, how do I educate other people to prevent relapse, to make sure that we're caring for all of our employees? So I think that's a great point.
Yeah, I'd like to just agree while disagreeing. I think it's a good point. We're talking here about opioids. You mentioned Adderall. It's true for all medications. There's a lot of harm when I'm just going to give you one of my antibiotic pills because you've got a cold. That's sort of a public health, societal thing that we need to do. And I'd almost counsel an employer, you can't have a policy about every single behavior that goes on. And, maybe you do have one that says you shouldn't share medications, but boy, there are a lot of other things you could tell people they shouldn't do also. And so I think it's right. I mean, when I think of Partnership for a Drug-Free America, I think of a very good public health agency that has changed public opinion over the course of some decades. I assume that's what that the New Jersey organization does as well. I think that's my personal belief, is that that's the role of organizations like that, almost more than the employer who, to have a policy about not sharing drugs, it's almost like there are a lot of things the employer is supposed to do also and that are higher on the priority list, in my view. It's an opinion. It's not proven by fact.
Hi, my name is Valerie Wright, and I just started. I'm a clinician by trade, but I just started as a substance use navigator for Middlesex County. Some of you may have heard of this new role. It's through a grant from the Division of Children and Families, Children's System of Care. And I have been going throughout Middlesex County, getting information from providers, from some of the other system partners like family support organizations, mobile outreach, DCP&P, Division of Child and Permanency, all of those groups. And I have to say, I'm disappointed and frankly appalled at the level of services that we now offer our youth. My last night working at a mental health facility, I witnessed an 18-year-old young man die from an overdose. So I switched gears. And what I'm finding is a lot of the parents and some of these system partners and organizations are struggling because they feel their hands are tied by some of the laws that govern our youth. Albeit a 14-year-old can decide whether or not they want their parent to know whether they tested positive for opioids or any other drug. They can also deny getting assistance. My question to you is, are there any laws currently being even considered to help parents have better leverage in getting their child care? for addictions. I have one parent that I've been working with lately. Her son is a danger, not only to himself, but to his family. He's been before the judge several times. Police have picked him up several times. They did several station house adjustment plans for this youth. He's been readdressed at the court, but the mom is saying every time they go to court, he gets a smack on the hand. We have to do something to hold these kids accountable for getting treatment, because I don't want to see them continue to die the way they are. And while they do have rights as individuals, the parents are sometimes being left to feel like they're being negligent when DCPMP says, Mom, you got to take him back home. And they say, no, I'm not taking him back home. We're all afraid of him. He's terrorizing us. Is there anything in process or anything even being thought of right now as far as the laws governing youth?
I'm not aware of any specific legislation. I could just talk about this as a policy aspect. It's a delicate balance. There was something called the PINS petition, Person in Need of Supervision, that certain states, New York, New Jersey, and others have been using, where a parent could go in and basically go to the judge, I'm fed up, my son or daughter is a drug dealer or doing this, a shoplifter, and, I want the court to intervene and, mandate behavior and take care of them. And we were seeing abuses. We were seeing people being incarcerated because they were basically, just a little bit of a wild kid, if you will. And so it's a balance, I think, between individual freedom and empowering parents, I suppose. But I think there are limits to what the law or the court systems can do to help people. I mean, I think it's more access. What Dr. Baker was saying, more access to treatment if we expand Medicaid and we make Medicaid more readily available so people could get services. And maybe some of the parents' reluctance is they can't afford it. They can't afford to get treatment for their children. But I don't know if necessarily expanding the intervention of the family court is going to really help. We already have laws on the books, where if you have a really terrible parent, you could, DIFAS can bring a petition and deprive them of their parental rights and this sort of thing. But and at the end of the day, some of it's individual responsibility. You're even a 16-year-old at some point has to take some responsibility for who they are and what they're doing and why they're doing it.
So just to comment from the clinical side, because I can't really comment from the legal side, our organization provides the mental health care coordination for the Department of Children and Family Services in the state of Florida. So I do understand what you're encountering and how frustrating that can be. And this is not easy to do, but I will say that the approach that we have taken is through our care managers. We have a couple of them who have extraordinary relationships with these patients, which have been built over time. At times it's taken years to build up these relationships, and some of these care coordinators will actually receive calls, whether it be a child or an adult will receive a call from them months later after they've already been off of the drugs, and they'll call them to say, I'm thinking about using, I'm debating going back to using. And so just having that open communication and that relationship, I think, between the care manager and the provider and the patient is something that we've been looking to combat that. But admittedly, it's very difficult.
And if I could just add, as a pediatrician, the rights of my patients, take a back seat to their health and their safety. So although they're individuals and they have rights, my job as a clinician and a quality and safety officer is their security and their safety first and foremost, and then I'll worry about their rights later. So the law supports pediatricians and gives them the benefit of the doubt. If a child is a harm to themselves or on the road to harming themselves or somebody else, then their rights go out the window. And I don't want to sound callous, but, rights of a 13-year-old are different than the rights of a 28-year-old. And the laws are different state by state, but generally, there's strict laws around reproductive health for minors and what they have to tell their parents, sexually transmitted disease treatment, substance abuse, and in some states you can commit yourself to an inpatient psychiatric facility if you're over 13 and your patients don't need to know about it. And the law protects you in not telling them about it. But, there's exceptions to those rules. So I think that requires more sensitive training on HIPAA, and really, because most pediatricians probably are not really familiar with the laws, and, when to report a family to Division of Youth and Family Services. There are a lot of sensitivities with people you have relationships with. But I agree, we have to give them all the tools, and the parents in most situations are the most important in helping their children make the right tools, assuming the family structure is there. And then it's complicated with the laws of emancipated minors, et cetera, et cetera. So I think it goes back to education and communication and, kind of not worrying about this litigious society. We have to always be mindful of it. But, medical care should not be driven by, what's going to happen if I don't do this or do this. You should, if you put the patient first, always, then I think everything else will fall into place. And it sounds simple, but, that's how it should be done.
Yeah, I'll add one comment, which is not really medical, but it's more. There are always going to be difficult and tragic cases, no matter what it is that we do. And I believe that population health is about managing populations, and we're better off if a very large percent, whether it's 90, 95, 99, I don't know, are doing it all well. And we have to, and there always are going to be tragic cases. And so I'm not sure we want to design a system for the tragic case. We're going to design a system for the tragic cases. And so, in America, we've chosen freedom is a really important thing, and so we don't commit people except in very limited circumstances. You're going to have to make your own decision about what that is, but we, in this and in other areas as well, there are tragic cases, and no different in addiction for sure.
I can't help it, I got to stand up here. Well, I just want to thank NJBIZ for doing this. It's a wonderful event. I know it's a lot of time to put this together, and thank you for all coming out. I lead the Chamber of Commerce in my town. My name is Joe Coyle. I'm also one of those politicians. I'm a councilman in my town. But unfortunately, we're the fifth largest municipality, so I do have a lot of access, and I'm loving what I'm hearing. But I started about 30 months ago, and I'm a parent of a recovering family member. And this homework assignment was just enormous for me. I've been on this homework assignment for 30 months now. And the other part I see is when you talk about different parts of the county getting more access for beds and things. Coming from a Chamber of Commerce perspective, I know how many hotel beds we have. They say beds and heads. When you look at if the message went out tomorrow and we all brought you 100 people, where would they go, and what are we doing about those demographic locations across the state that don't have enough facilities? And I face, if a facility comes to my town, of course I'm going to hear a thunder from my neighborhood, whether it's a sober house or it's I don't know all the names, inpatient, outpatient, a bed facility, but for whatever it is, where are we with the laws or inspiring or encouraging more beds for the treatment? And how many qualify if this whole room came to you? Because when I made the phone calls as a parent, it was tough. I didn't get that many people on the phone, that many people wanted to talk to me. It was cash only. So the beds, if we get the message out, and where would they go, and what's changing across the counties is my true question here. And thank you for all you've done.
Well, I can talk a little bit about how we handle it through Seabrook. I think what you point out is a huge problem because there's not really good coordination to say, we know there's X number of treatment beds in this state or this county. Seabrook, we've been doing this for 43 years. We have relationships with treatment facilities and mental health programs throughout the country. We have a call center that when folks call in, if we can't provide the services they need, we have a team of people who could refer them out to other facilities, whether they be for-profit facilities such as the RCA system or a wide range of other inpatient and outpatient systems throughout the country. I know the state has had many efforts. There's been an increase in mental health beds, which definitely helps because of the co-occurring population. But I think there's a lot of work that needs to be done from an addiction recovery standpoint in terms of identifying what those resources are, identifying how we pay for them, because we're forever with challenges with getting the payment, getting the length of stay. Insurance companies believe that, or at least have in the past believed that you can cure an addiction in 28 days. 7 days of detox, 21 days of rehab, and everything's done. And that's not the case. Science shows that you need at least 90 days, if not longer, for the changes that have happened in a person to begin to resolve. So I think you point out a serious issue that needs to be addressed in terms of the capacity to deal with the beds and the inpatient and outpatient treatment that is needed to address this problem, because there are far more people who are suffering from addiction issues than there are beds and facilities to treat them.
And I think it's a resource problem. I've said it a couple of times this morning. Democrat or Republican, it just seems to be that their focus is on treating this whole situation as a law enforcement problem. And so creating more task forces at the state and federal level. The Attorney General's just created another task force. And I think Bill's right. I think we need more money for more beds and more facilities. And, maybe Governor Murphy will change that, that transition some of these resources and treat it more as a health crisis than a law enforcement crisis.
And if I can just add, too, in terms of the public health system, that some of the challenges have been resources and available resources. And Medicaid has just recently had approval to be able to have Medicaid reimbursement in residential treatment where it wasn't available before unless you were under the age of 21 or over the age of 65. So that's going to create some greater resources as well. And I just want to highlight as well that not everyone who enters treatment necessarily needs residential level of care. And we have many different levels of care and treatment that are available. Individuals don't necessarily have to go into an inpatient facility for withdrawal management, for detox services. And so those are some of the models that we're also looking to further as well, so that individuals receive the support and the treatment that they need in the appropriate level of care, so that those who need the deeper end services have them available. And so in terms of the public health system, individuals can call up the interim managing entity, New Jersey's interim managing entity. You can Google that online. They're open 24 hours a day, 7 days a week. And they will help individuals to access treatment from the most intensive inpatient detox all the way up to outpatient services.
Question?
Thank you. Thank you to the panel, to the moderator, and NJBIZ as well. This has been really excellent. And I just want to say that, I have over 30 years as an HR practitioner, and I also happen to be a man in long-term recovery, which for me means I haven't had a drink or a drug since October 10th of 1989. And a lot has changed since I began my journey in recovery. And there's a lot of obstacles, and I think it was said best that, addiction is a very complex issue with lots of moving parts. Therefore, recovery can't be a cookie-cutter solution. And it's in that spirit I want to get the panel's feedback on. And anybody here, that came to this event today hoping to hear some solutions from an employer's perspective, as the title dictates, its effect on the workforce. I work with people one-to-one as a certified peer recovery specialist. I was co-authored in that designation, and it's recognized by the International CERT Board. But the reason why I bring this up is that as a peer recovery specialist, we meet people wherever they are, not where we think they should be. And we give them a voice and allow them to take ownership of their recovery. So you started out the session by saying, what is addiction? I would like to hear what is recovery, especially when you take into consider things like harm reduction, because what works for me might kill somebody else, and vice versa. Thank you.
Well, first let me say congratulations, and I applaud you for your recovery. That's absolutely awesome to hear, and it warms my heart when I talk to somebody who has been able to be successful. As you know, not everybody can be successful. Relapse is a natural part of this. Many people do relapse, and it takes a few tries for folks to get there sometimes. But I think you make some great points in that it really is an individual journey for everyone. There's no cookie-cutter solutions. Recovery looks different for people. Our goal, we were an abstinence-only facility for many, many years, but we've recognized the need to kind of expand that approach and realize that not everyone is ready for abstinence. Sometimes it's more important to reduce harm and save a life and then work on trying to get them into recovery. Many of our young opiate population just are not ready for going fully to abstinence. So we've adopted medication-assisted treatment. We have we won't do medication-assisted treatment without the biopsychosocial wraparound, whether they go to one of our intensive outpatients or our PHP programs. It's a very there's no one answer for what recovery really is for people. We do our very best to get people back to as normal a life as possible, to reestablish the relationships, hopefully return to a career. But really, each individual needs to figure out what their recovery needs to be, and we'll help them to get there. So that's really where we focus at Seabrook. We follow people for life, and a lot of times. Our alumni program is huge. We will track people. We have people come back to the campus, participate with our alumni program. In fact, our biggest referral source is our alumni program. So it really becomes a family and a community that is in recovery and supports one another in recovery.
And I would just add, I don't deal with mental health and addiction. I work with our teams, but I would say recovery is not an outcome. It's a journey that continues. You can speak to that better, but when somebody battles addiction and is abstinent, it doesn't end there. I think there's still a lot more challenges every single day. And as clinicians and support staff and patients understand that, I think recovery is a lifelong process and fight, and you need all the support and tools you can get.
Yeah, I agree. And this is probably more, well, it's not only personal, but, there are people who are abstinent yet not recovered, and people who are using and yet recovered. And to me, that's just what it looks like. Nothing more.
And I think just to add as well, so, the U.S. SAMHSA, Substance Abuse Mental Health Services Administration, really identifies that there are 4 major dimensions that support a life in recovery, and employment is one of them. And so we spent the morning really talking about employment. Employment really is a strong contributor to, someone's success as it pertains to the recovery. So I thank you all for being here, and I thank my panelists.